My name is Jack Johnson. Welcome to my presentation on pharmacogenetics and your medical practice. Physicians have intuitively known ever since olden times that there are invisible factors within each one of us that predetermines how we respond to certain therapies. Nowadays, your patients are starting to see ads from attorneys which are seeking to litigate medical mistakes. There are many reasons to test your patients. Among the most important ones may be the first one on this slide. A recent UCLA Journal of Law and Business has already published an extensive article on it. Pharmacogenetic testing is a tool currently available to assist you in your practice. Not using it proactively can and likely will have an adverse effect on your practice in the form of liability. The FDA has also chimed in on the importance of Pgs testing and has posted over 130 FDA-approved drugs with Pgs warnings prior to prescribing. In 2013, the following institutions implemented Pgs testing: Cornell, Columbia, Georgetown, Harvard, the Mayo Clinic, Scripps, Stanford, Vanderbilt, just to name a few. Traditional medicine is practiced in a reactionary manner as opposed to a proactive manner, which leaves the patient at risk for avoidable adverse drug reactions and even death. Let's talk about drug metabolizing phenotypes. There's UM, EM, and IM, and then there's also PM. And as you can see from this slide, the UM increases enzyme, EM is normal, IM is impaired, and PM is non-functional. Over 70% of all drugs are metabolized through the liver. One of the main enzymes that metabolizes drugs in the liver is CYP450 family of enzymes. Drug, or more specifically gene-drug, interactions are influenced by any and all of these processes. If a patient is a normal metabolizer with no pathway issues, their metabolism via a particular pathway may be affected so as to make them behave as an intermediate or even a poor metabolizer. Example, the patient is a normal metabolizer of Plavix, which utilizes CYP2C19 pathway. If the patient takes a drug that is a strong inhibitor of CY2C119, let's say Lopoid or Dipocan, while taking Plavix, the drug is not metabolized and rendered useless. The interaction makes the patient, in effect, a poor metabolizer of CY2C19 medications. As previously discussed, the GPX report alerts the physician to these type of interaction and gives him the tools necessary to avoid any adverse drug reactions and also the ability to use the appropriate alternative therapy. This is a very important slide because it shows the discrepancy of proper dosage in a person based on their ability to metabolize a given drug. As an example, a patient that is a poor metabolizer of Plavix may be given a dose of 60 milligrams, whereas if that same patient were an ultra-rapid metabolizer, the patient should be dosed at about 135 milligrams. The only way you would know this is if you gave that patient a Pgs test. Let's take a look at 4 case studies that will illustrate some potential problems that physicians see in their practice and how a simple buccal swab Pgs test before dosing can result in dramatic different patient outcomes. This case study has been documented more than once in literature and is very concerning to me because it affects more than one life. Let's take a look at the statistics. 10% of Caucasian and approximately 3% of African Americans are ultra-rapid metabolizers. That is, approximately 13% of the patients are susceptible to this outcome on any given day. Physicians strive to keep patients from experiencing their first acute MI, which is why clopidogrel is prescribed post-acute MI. Pgs testing can play a significant role in avoiding subsequent acute MIs as described in this case study, so much so that the FDA has placed a warning about diminished effectiveness in poor metabolizers. This study describes issues surrounding proper dosing of warfarin and how seriously it impacts patients that have a phenotype variation that alters metabolizing warfarin. This study shows how a 9-year-old boy with ADHD was given Prozac and he could not metabolize it, and he had built up a very toxic level before anyone recognized it. And unfortunately, this patient did succumb to those toxic levels and died. Perhaps one of the most compelling personal reasons why physicians should consider adapting Pgs testing in their practice now rather than later is risk management. The next couple of slides discuss this very sensitive subject. The quotes on this slide were taken from a journal article about what's coming down the pike for physicians in risk management as it relates to the availability of PGX testing, which clearly demonstrates that if you have the ability to offer this testing and are not doing it, you can still be found liable. The courts are already finding that physicians have a duty to test patients, and failure to do so can constitute medical malpractice. One of their successful theories have been lack of informed consent. If a patient was not given the opportunity to be tested or declined the test with language that informs the patient about the risk of not taking advantage of this new technology, physicians can and have been found liable even when the physician has not been aware of existing PGX tests. This is just one example of a PGX test which shows if a patient has the ability to metabolize a particular drug. This is another example of a PGX test that shows a particular drug and if it is metabolized properly by a patient. We provide you with a physician portal which will allow your staff to enter the patient's demographic information with respect to insurance, etc., and in 0.38 seconds it will respond to you with respect to if that patient is approved for this test through its insurance carrier or not. As you can see, not only is there benefit to testing to get better outcomes for your patients, but this test can also be financially rewarding to your practice. One question remains. Now that you have reviewed the risks and benefits of implementing pharmacogenetics testing in your medical practice, why wouldn't you begin testing your patients now? These are simply the reference points that we gleaned our information from. Thank you for your time and listening to my presentation, and please click on the link and fill out our form, and I will respond back to you within 24 hours and give you a more detailed evaluation of your practice and show you how you can implement PGX testing. Thank you.